at different tests and procedures, and then compatibility testing. And then we have essentials of pre-transfusion, yung ating donor screening, and lastly, component preparation, and lastly, yung ating transfusion reactions. So, let's start with hemolytic disease of newborn. So, this is actually a special topic sa blood bank, HDN, kasi during board exam, marami lumalabas. And then, actually, very important din siya kasi marami, kung mapapansin ninyo, isa siyang buong topic. Okay? So, let's start with, HDN. So, hemolytic disease of newborn. This is a clinical condition caused by destruction of red blood cells of the fetus and neonate by antibodies produced by the mother. So, as you can see, may hemolysis na nangyayari wherein the antibodies produced by the mother are attacking the antigens of the fetus or the neonate or the baby. So the mother can be stimulated to form antibodies by, okay? So kasi guys sa HDN, ang pinag-uusapan natin dito, si mother wala siyang antigen dapat. Okay? So paano na gumagawa si mommy ng antibodies? It can be triggered or stimulated by previous pregnancy, transfusion, second and third trimester of pregnancy. And we have also here the three main factors, okay, na kailangan para daw magkaroon ng hemolytic disease of newborn. So, what are these? So, number one, the mother must lack the antigen, and following exposure to antigen from previous pregnancies or transfusions produce an antibody of the IgG class. So sabi dito guys, dapat daw si mommy walang antigen. Okay, tapos si mommy na walang antigen, kailangan niya ma-expose doon sa dugo na may antigen, and then syempre si mommy gagawa ng antibodies against that antigen. And the antibody should be of IgG class. Okay? Next, number 2. The fetus, okay, must possess the antigen. And sabi dito, father is homozygous, okay? Kapag na-inherit niya to, homozygously, 100% magkaka-HDN si baby. Pero 50% lang daw pag heterozygous. Okay? And number 3, yung antigen dapat na meron sa surface ng RBC ng fetus natin should be well-developed at birth. So tatandaan natin yung tatlong factors or the three main factors that must be present for HDN to occur. So we have here the disease mechanism. So paano ba nangyayari? Or, paano ba nangyayari yung HDN? So this is caused by the destruction of red blood cells of the fetus by antibodies produced by the mother. So, anong nangyayari nga? Sabi ko, the mother will produce an antibody against the antigen of the fetus. And once that antibody is produced, that antibody will cross the placenta and will attach or bind or attack the antigen of the fetus. And again, anong immunoglobulin class dapat ang nature or nature ng antibody ni mommy? It should be what? Sino na kasi yung antibody natin or immunoglobulin natin na actively transported across the placenta? That's yours?
IgG.
Lahat. Okay, lahat ba ng subclasses ng IgG kayang mag-cross ng placenta?
Hindi, sir.
Except
IgG2.
Very good. Pasulat, immunoglobulin G except IgG2. Again, lahat ng immunoglobulin G, 1, 3, and 4 can cross the placenta. So, ibig sabihin, the antibodies na may class or subclass ng IgG1, 3, and 4 kayang mag-cross ng placenta. Okay? And dito pa, sabi pa dito, the transfer of antibodies from mother to fetus. Guys, anong type na kasi ng immunity kapag ganito? Transfer of antibodies from mother to fetus?
Passive, sir.
Acid natural transfusion.
Ano ulit? Anong acid?
Acid natural.
natural.
Okay. passive natural. Bingi lang pala ako. Pasensya na. Oo. Passive natural, di ba? May advantage yun, di ba? Okay, ano yung advantage? Ayan niya. Sabi, most IgG antibodies are directed against bacterial, fungal, and viral antigens. So the transfer of IgG from the mother to fetus is very beneficial. Pero, ang disadvantage, pwedeng magka-HDN si baby if, yun nga, ma-meet natin tong mga factors na to. Okay? So, baba tayo. Actually, there are two main classes of hemolytic disease of newborn. So that's Rh hemolytic disease of newborn and HDN. So papatanda ko pa lang sa inyo ngayon na ang Rh HDN natin or Rh hemolytic disease of newborn is associated with the most severe cases of HDN, but your ABO HDN is the most common, okay, type of HDN. Again, most severe ang Rh-HDN, ABO-HDN naman natin is most common. So kung makapapansin natin dito, ayan, Rh-HDN tayo. So start tayo Rh-HDN. Sa first pregnancy, the the mother is Rh negative. And then the firstborn, again, first pregnancy tayo firstborn is Rh positive. So meaning si mother walang D antigen. Guys, pinag-uusapan natin ng Rh. Naalala ninyo, di ba? Pag Rh positive, Rh negative, it refers to the presence or absence of big D antigen. So wag na tayo malilito doon. Okay? So Rh negative mother, walang big D antigen si mother, si baby or the firstborn merong D antigen. Unaffected daw si baby. So tatandaan natin na sa firstborn, kapag si mother Rh negative and then si baby Rh positive, the firstborn child ni mommy, unaffected ang baby. So sabi
Kasi pa.
ay, bakit? Kasi, sino yon?
Sir, wala po.
Bakit? May kaaway ka ba dyan? Sino ba yun? Si Vernice? May kaaway ka ba dyan, Vernice?
Sir, wala po, sir.
Okay. Nalito ka lang. So, sabi dito, during gestation, okay, sa pagbubuntis daw ni mommy, and particularly at the delivery, when the placenta separates from the uterus, okay, anong sabi dyan? Lang. Ay. Okay. Okay, variable numbers of fetal red blood cells enter the maternal circulation. So ang tawag dito is FMH. Wag na malilito Pag sinabi kong FMH, hindi ito FHM, okay? FMH, fetal-maternal hemorrhage. Sa fetal-maternal hemorrhage natin, yung mga red blood cells na baby papasok sa circulation ni mommy. Kailan daw ito nakikita? Kapag yung placenta daw, mase-separate na sa uterus. Kailan nangyayari to? Seen in, during, amniocentesis, spontaneous or induced abortion, chorionic villus sampling, ectopic pregnancy, and abdominal trauma. So let's imagine, yung fetal red blood cells natin, carry, okay, nasa surface ng fetal red cells natin yung D antigen na na-inherit ni baby sa tatay. And then, si mommy mai-immunize. Ibig sabihin, pumasok yung fetal cells na may D antigen sa surface ng RBC ni baby sa maternal circulation ni mommy. So, na-immunize siya ng D antigen. Si mother walang antigen. So, anong gagawin ni mommy? Gagawin ni mommy, si mommy magproproduce ng anti-big D. Naintindihan ba yon? So once the mother is immunized to big D antigen, lahat ng mga susunod niyang anak, all subsequent offspring inheriting the D antigen will be affected. Okay? So kung mapapansin ninyo dito sa picture natin, so yung pathogenesis, so nagkaroon ng fetal-maternal hemorrhage. So anong mangyayari? Si maternal antibodies form against the paternally derived antigens. Ibig sabihin yung antibody na produce ni mommy against the antigen na namana ni baby kay daddy. So during subsequent pregnancy, placental passage of maternal IgG antibodies. So maternal antibody attaches to fetal red blood cells and fetal red blood cell hemolysis will occur. So kung mapapansin ninyo, 'di ba? Ito si baby. Okay? Ito si mommy. Okay, buntis siya. Okay? So kapag nagkaroon daw or nagkaroon for example ng abortion or mga ectopic pregnancy or abdominal trauma or basta yung placenta na separate sa uterus, yun na yun. Yung mga red cells ni baby, okay, na positive ng D antigen pumasok sa katawan ni mami. Na-expose si mami sa D antigen. So anong mangyayari? Si immune system ni mami mag-react. So anong mangyayari? Gagawin ng immune system ni mami, uy, kailangan kong gumawa ng antibody against that antigen. So gumawa si mami ng maraming anti-D. Uy, si anti-D, IgG. At kayang mag-cross ng placenta. Ngayon, papasok nga ako dito sa mag-cross nga ako sa placenta. So kung mapapansin niyo, itong antibodies na to nag-attach sa red cells ni baby na may D antigen. Anong pwedeng mangyari? It can lead to lysis. Okay? Magla-lyse na yan. Okay? Okay, naintindihan ba? Hello? Pa-type naman ako ng 1 kung naintindihan. Okay. So, napag-usapan natin yung firstborn na anak ni mommy, affected or unaffected? Unaffected. Okay, doon pa lang nag-produce si mommy ng antibody. But, on subsequent pregnancies, okay, sa mga susunod niyang mga anak, okay, dahil si mommy at daddy active, okay, active kasi sila, syempre nabuntis ulit si mommy. So si mommy again, Rh negative, and then si baby Rh positive. Here, affected na si baby at meron na siyang HDN. So because the Rh negative mother, nag-form na siya ng anti-D na na-produce noong unang pregnancy niya. Ulit-ulit, anti-D is an IgG that can cross the placenta. And then Rh positive naman si fetus, meron siyang D antigen sa surface ng red cells niya. Therefore, there is a reaction, anti-D attaches to the D antigen of the fetus leading to hemolysis, HDN. Alright? Naintindihan ba? Yes. Hello?
Yes po, sir.
Yes, sir.
Hi, sir.
Hi, sir.
Hi! Oo. Ayan. Okay. Uy, thank you pala sa mga nag-pray sa akin. Pray talaga. Kasi I'm so stressed for the past few days. Hindi lang halata. So, factors affecting immunization and severity. So, antigen exposure. Guys, basahin nyo lang to, hindi masyadong importante. Nilagay ko lang siya kasi natin. So, sabi pa nga dito, IgG1 and IgG3 are more efficient in RBC hemolysis. Okay? So, basahin nyo yan. So, proceed tayo sa pathogenesis. So, sa pathogenesis natin, very important. Laging tinatanong to sa board exam. Okay? So, ano yung effect kapag si baby nasa loob pa ng sinapupunan ni mommy? At ano yung effect pagkalabas sa tiyan ni mommy kay baby? Okay? Kay baby, ano yung effect kay baby? Okay? Inom lang ako. Okay. So, saan na ba ako? So, sabi dito, hemolysis occurs when maternal IgG attaches to specific antigens of the fetal red blood cells. So, what are the antibodies na nakikita during sa prenatal specimen? So, mga commonly seen antibodies are anti-D, anti-D in combination of C, anti-D in combination of E, anti-C alone, anti-big E, anti-small c, E, and anti-K din pala, yung KEL natin. Okay, nakikita rin yan. So, ano nangyayari? Okay, so alam nyo na to guys, di ba? Kapag na-lyse ang RBC, maliliberate si, or sino yung ma-release? Yung hemoglobin. Kapag na-liberate si hemoglobin, di ba, ma-metabolize siya into indirect bilirubin. Guys, pinag-uusapan dito si baby ha. So indirect bilirubin is transported across the placenta, conjugated by the maternal liver and harmlessly excreted by the mother. Kasi nga, 'di ba, yung liver ni mommy is mature. 'Di ba? Meron siyang glucuronil transferase na enzyme. 'Di ba naalala niyo yung glucuronil transferase, yun yung nagko-convert ng indirect bilirubin into direct bilirubin. So si mommy, si mommy sa kanya, okay, i-harmlessly excrete niya lang yung indirect bilirubin. However, sabi dito, pag-usapan natin si baby, however, as RBC destruction continues, tuloy-tuloy na nasisira ang RBC. Yung fetus natin become extremely anemic. Meaning, sobrang baba ng red blood cell ni baby kasi tuloy-tuloy ang pagkasira ng RBC. So anong compensatory mechanism ang gagawin ni baby or ni fetus? Siyempre, yung fetal bone marrow or yung bone marrow niya, okay, magproproduce ng napakaraming red blood cells, okay, at an accelerated rate. Even to the point na pati yung mga immature red blood cells natin napoproduce na at napupunta sa circulation or peripheral blood circulation ni baby. Okay? Kasi nga yun yung compensatory mechanism ni baby eh. Uy, anemic na si yung fetus. So gagawin ni fetus, magproproduce yung fetus ng napakaraming RBC until to the point na pati yung mga blasts or immature red blood cells natin or what we call erythroblasts mapupunta sa peripheral blood circulation. And that's what you call now erythroblastosis fetalis. So what is erythroblastosis fetalis? This is actually a combination of anemia at kapag nakita daw or there is the appearance of immature red blood cells or erythroblasts sa peripheral blood ni fetus. Okay? Erythroblastosis fetalis. Huwag kakalimutan. Ngayon, kapag yung bone marrow ni baby hindi na kayang mag-produce ng RBC to keep up with the rate of RBC destruction. Naalala nyo ba ang extramedullary hematopoiesis? Diba? Pwede tayong, hindi lang naman si bone marrow ang kayang mag-produce ng RBCs. Hello? Meron pang iba. That's what you call extramedullary hematopoiesis. Saan? Outside the bone marrow, saan? Sa hematopoietic tissues, sino-sino? Ano yon? Yung spleen at liver. So yung si spleen at liver na ang magtuto the rescue doon sa bone marrow ni baby. O kami na, si spleen at liver na daw ang bahala para mag-produce ng RBC. Kasi nga, tuloy-tuloy pa rin yung destruction ng RBC. Eh ano mangyayari? The spleen and the liver become enlarged. At meron ng hepatosplenomegaly, pagkalaki ng liver at spleen because overuse yung spleen and liver natin para mag-produce pa ng RBCs dun sa part na yon. And this can lead to portal hypertension and hepatocellular damage or pagkasira ng mga hepatocytes or liver cells. So ano pang mangyayari? So when the resultant of the damaged hepatocytes, so sira na yung liver cells ni baby, magkakaroon ng hypoproteinemia or decrease protein level sa blood ni baby. Bakit? Kasi nga decrease yung hepatic production ng plasma proteins. Kung maalala natin, ang plasma proteins are produced by the liver. Uy, sira ang liver ni baby. So may hypoproteinemia. And then after that, there is a development of high output cardiac failure with generalized edema, effusions, ascites, which is a condition known as hydrops fetalis. But sa other book, sabi kay hydrops fetalis, it is a combination of severe anemia and hypoproteinemia. Okay? So that's hydrops fetalis. And sabi nga dito, thus, the greatest threat to the fetus is cardiac failure. So yun yung papatay kay baby. Okay, yung cardiac failure na tinatawag. Okay, hindi na kaya ng heart niya to pump blood all over his or her body. Okay? So tatandaan natin yon yung ating hepatosplenomegaly, hydrops fetalis, and yung ating erythroblastosis fetalis. So ano naman yung effect sa postpartum? Okay, pagkaluwal kay baby, okay, naipanganak na siya, anong mangyayari? So intindihin to. The process of RBC destruction goes on even after such an infant is delivered alive. So tuloy-tuloy pa rin pala kahit napanganak na si baby, okay, nailabas na siya, nailuwal na siya, tuloy-tuloy pa rin ang pagkasira ng RBC. In fact, as long as maternal antibody persists in the newborn infant circulation, tuloy-tuloy pa rin yan. Kasi nga, yung explanation dyan, yung antibody natin is an IgG. So sabi dito, it is distributed extravascularly and intravascularly and has a half-life of 25 days. So antibody binding and hemolysis of RBCs will continue for several days to weeks after delivery. Alright? So sabi dito, okay, basahin natin ha. Intindihin natin ano nangyayari. So the RBC destruction continues with the release of indirect bilirubin. So from yung RBC nasira, na-release si hemoglobin, mami-metabolize into indirect bilirubin. So yung newborn liver, hindi pa siya mature. So wala pang glucuronil transferase. As we all know, yung glucuronil transferase kasi this is an enzyme responsible sa conversion ng indirect bilirubin into direct bilirubin. Kasi ang indirect bilirubin or yung ating tinatawag na B1, B1, 'di ba toxic 'yan? So sabi pa dito, as the indirect bilirubin is released, syempre may transport protein ang ating indirect bilirubin, 'di ba? Magbabind ang indirect bilirubin sa albumin and pwedeng mag-circulate si indirect bilirubin harmlessly. Pero kapag hindi na kaya ng binding capacity ni albumin, okay, kulang na si albumin para i-bind pa ang indirect bilirubin. So, ano mangyayari? Siyempre, lulutang si indirect bilirubin at mag-a-attach na yan sa tissues ng baby. Kaya nga, ayan, magre-result siya sa jaundice. Ano yung jaundice natin? Yellow discoloration of the skin. Alright? So in particular, ito very important, laging lumalabas sa board exam. It may bind to the CNS tissues and can cause permanent and irreversible brain damage, and that's what you call kernicterus, which can lead also to deafness, mental retardation, and of course, death. Okay? So tatandaan natin, dalawa yung pwedeng mangyari kay baby pagkaluwal, kapag may HDN siya, yellow discoloration of the skin, jaundice, and malala kapag nag-bind yan sa CNS tissues. That's what you call kernicterus. Okay, naintindihan ba? Type press 2 kung naintindihan. Yes naman. Naintindihan ba? Ayan, napaka-active ah. Alright. Uy guys, thank you pala for joining yesterday. Kailangan ko lang kasi yon kasi kailangan ko mag-record para dun sa pinagpapareviewhan ko, ipe-play ko kasi yon. No? Actually, magaling si RJ, no? Hello?
Yes, sir.
Oo. Pogi pa siya, no? Pero bading din yun. Nahalata niyo yung bading agad, si RJ? No?
Yes, sir.
Yes, sir.
Oh, ay makakano si Heartwick ah. Alam niyo na ba, na-appreciate ko yung friend ko na yun kasi bumiyahe pa siya. 'Di ba pwede naman kasing mag-join na lang sa Zoom meeting, 'di ba? Alam mo ginawa niya, bumiyahe siya from Laguna going here para dito daw siya mag-present and all, ganyan-ganyan. Sana all, 'di ba? O effort, o bet niyo 'yon. Okay. So, balik tayo. Asan ba? Ayan. So, ayan o, tingnan nyo yung diagram. So, hemoglobin, magiging indirect bilirubin, neonatal liver, immature, wala pang glucuronil transferase. So, indirect bilirubin, toxic, diba si indirect bilirubin, pwede siyang mag-bind sa albumin, hindi na kaya ni albumin yung dami ni indirect bilirubin. Anong mangyayari? Si indirect bilirubin mag-a-attach sa tissues at malala kapag sa CNS tissues, kernicterus. Si mommy, ayan, maternal liver, mature, so pwede niyo i-convert into direct bilirubin and ayan, harmless, okay, which is excreted by the mother. So yon. May tanong? Hello, do you have any question? Hi. Hello. Hello.
Wala po, sir.
Wala po.
Answer. Opo, sir.
Okay lang kayo?
Yes, sir.
Yes.
Yes, sir.
Po.
Okay, na-miss ko naman kayo. Ay, wait lang. Dapat ba separate yung exam ninyo? A and B lang to, no?
Sir, hindi ko pa po nabasa yung part na to, sir.
Basahin mo na lang, oh. Basahin mo na lang. O, sige, basahin mo. Ayan. O, go.
Legit, sir. Basahin ko lang, sir.
Oo nga. Nagbibiro ba ako? Mukha ba ako nagbibiro?
Sige po, sir.
Mm-mm.
For the serologic testing, the recommended obstetric practice is to perform a type and an antibody screen. Wait lang, sir. At the first prenatal visit, preferably during the first trimester. And at the time, the pregnant woman can be asked about previous pregnancies and their outcomes and prior transfusions. Previous severe disease and poor outcome pre-direct similar findings in the current pregnancy. So, sir, ang sinasabi niya dyan, so,
Go lang.
sinasabi niya daw dyan, sir, kapag daw may, sa first, sir, kailangan mong alamin yung pregnant woman kung about sa history niya or previous pregnancy, sir, para magkaroon ng idea about dun sa test na i-conduct sa kanya, sir.
Yes, okay.
Or
So,
AB,
sige. More of, like, kailangan malaman yung history ng pasyente, ng babae. Siyempre, dapat malaman, siyempre, alam na nung doktor or ikaw mismo, alam mo ng RH negative siya. So, dapat malaman mo kung unang, pagbubuntis niya ba to, or nabuntis siya pero nalaglagan. Alam mo yung mga ganon. Very important yung mga ganon. So, pag sinabi natin serologic testing, guys, it comprises of, number one, syempre, kailangan natin i-ABO and RH test typing si mommy. Okay? So, RH test should also include week D. Naalala niyo ba si week D? Okay? If no immediate reaction with anti-D occurs. So, di ba, nag-week D tayo pag negative sa routine RH typing. Okay? So, if the patient is week D positive, the patient can be considered RH positive. So, hindi pwede, yung tendency to have, yung tendency to have RH HDN is less likely, okay? Okay. So, antibody screen naman. Okay, guys, okay, ito, i-discuss ko na sa inyo because we're going to discuss this on finals, yung antibody screening and antibody identification. So, when we talk about screening, i-screen lang natin yung dugo ni patient kung meron bang antibody. Okay? Sabi dito, the test conditions must be able to detect clinically significant IgG antibodies that are reactive at 37 degrees Celsius and antiglobulin phase. So meaning, while screening the blood of the patient, okay, so kailangan guys, madali lang, kapag nag-react yan sa 37 degrees Celsius at antiglobulin phase, ibig sabihin ang antibody na yan IgG. So yun pa lang yung screening phase natin. So tatandaan natin, wag nating isali ang immediate spin or room temperature phase kasi madedetect natin ang IgM antibodies. So wag nating isali ang IS or RT phase to reduce detection of IgM antibodies. So next, after screening, so na-screen na natin. Okay, so mayroon na tayong clue. Uy, IgG siya. Nag-react siya at 37 and antiglobulin. Ngayon, pwede nating i-identify kung ano ba yung antibody na yon. In this method, called reactive IgM antibodies such as anti-Big I, IH, anti-Lewis A, anti-Lewis B, anti-P1 can be ignored. Okay? To establish immunoglobulin class, the serum can be treated with what we call sulfhydryl reagents such as DTP or ditritol or 2-mercaptoethanol and then retested with appropriate controls. So tatandaan ninyo, IgM destroyed because the J chain is also destroyed. And the IgG here remain active. Okay? If the antibody specificity is determined to be clinically significant, okay? Clinically significant. Ano daw yun? Sabi. The antibody is IgG. Further testing is required. Other than anti-D, the most common and most significant antibodies that causes HDN are anti-Big K, Big E, anti-Big C, and anti-Daffy A. So tatandaan, nakabold yan. Hindi lang pala si anti-D ang nagkakos ng HDN, pati pala itong mga to. Next, paternal phenotype. Pwede din natin gawin para malaman kung anong antigen meron si baby. Amniocyte testing or yung mga cells natin sa amniotic fluid natin. So sabi dito, if the mother has anti-D and the father is most likely to be heterozygous for the D antigen, amniocentesis can be done as early as 10 to 12 weeks gestation to determine whether the amniocytes or the cells there carry the gene of the D antigen. Amniocytes can be similarly tested for the genes coding for C, C, EK, Daffy A, Daffy B, Kid A, Kid B, and Big M. So antibody titer. Alam niyo naman ang ibig sabihin ng titer, di ba? Yung concentration ng antibody. So pwede natin gawin ng antibody titer. So we determine the relative concentration of all antibodies capable of crossing the placenta and causing HDN. So ang critical titer natin is 16 to 32. So sabi dito, if the initial titer is more than 16, second titer should be done at 18 to 20 weeks of gestation. So constant titer naman of 32 or above represents an indication of amniocentesis, which is papag-usapan natin mamaya, okay? Or what we call PUBS, percutaneous umbilical blood sampling between 18 and 24 weeks gestation. If the titer is less than 32 naman, the titer should be repeated at 4-week intervals beginning at 18 to 20 weeks gestation and every 2 to 4 weeks during the third trimester. So titration studies at time of delivery are not recommended as they provide no clinically useful information. Okay? So, yun lang. Let's proceed. We're done with serologic testing. Ano bang pwede natin gawin? Amniocentesis. Okay, ano ba ang amniocentesis? So here, in amniocentesis, my dear friends, kung mapapansin ninyo, okay, there is an insertion of needle through the mother's abdominal wall and uterus, and extraction of fluid from the amniotic sac. So, ang mangyayari, may needle, ipapasok sa abdominal wall, until makakuha tayo ng fluid doon sa amniotic sac. So under ultrasound guidance, amniocentesis is done to assess the status of the fetus. So it represents an indirect prediction of severity of fetal anemia. So yung analyte na itetest natin doon sa amniotic fluid na nakuha natin sa amniotic sac is yung ating bilirubin. So the concentration of bilirubin pigment in the amniotic fluid correlates to the or with the extent of fetal anemia. So kung naalala ninyo, sa analysis of urine and body fluids natin, di ba, gumagamit tayo ng Lilly graph. Kung naalala niyo yung Lilly graph, di ba? Yung optical density at 450 nanometers, okay, scan natin yung bilirubin using spectrophotometry, and then makakalculate na yan. And then change in optical density, ipa-plot natin sa Lilly graph, and according to gestational age, and values on. So tatandaan lang natin itong mga to. Zone 1 represents mild or no disease, which do not require intervention. Zone 2, moderate disease that may require intervention. Zone 3, severe and life-threatening hemolysis. Here, the fetal hemoglobin is less than 8 grams per deciliter and require urgent intervention. So, based on this testing, 3 alternative exists. Dito natin malalaman kung i-allow ba natin yung pregnancy to continue, or we can perform intrauterine transfusion, or ibig sabihin ng intrauterine transfusion, transfusan na natin yung fetus habang nasa loob pa siya ng tiyan ni mami. Di ba? Ang galing. Pwede natin transfusan yung fetus, okay? Or we can now induce early labor. So, yon ang ating amniocentesis. So, what about chordocentesis? Magkaiba sa amniocentesis. Ay, naglolo ko nga. Chordocentesis, or what we call percutaneous umbilical cord sampling. Here, it is a process of obtaining fetal blood using ultrasound-guided needle in the umbilical vein near the point of placental insertion. So doon daw naman tayo kukuha ng dugo. Doon sa may umbilical vein, malapit sa placental insertion. So as you can see sa picture sa taas, okay? So saan ginagamit yung sample na nakuha doon? Pwede natin siyang gamitin for direct antiglobulin testing to determine the hemoglobin, hematocrit, bilirubin, to test ABO and RH typing ng baby, antigen, phenotype, and genotype. So in severe cases of HDN, yung percutaneous umbilical blood sampling can also be used for direct intravascular transfusion to the fetus. And I have a note here, yung amniocentesis natin and chordocentesis have several risks. Among them, trauma doon sa placenta, which may cause increased antibody titers because of antigenic challenge to the mother through fetal-maternal hemorrhage. Tama naman, di ba? Mas magkakaroon ng trauma doon sa part ng placenta, so mas maraming mai-introduce na fetal red cells doon sa maternal circulation or sa circulation ni mommy. Therefore, mas tataas yung concentration ng antibody, kaya tumaas yung antibody titer na, for example, anti-D. Okay? Gumagamit din tayo ng color Doppler middle cerebral artery peak systolic velocity. Just so you know lang ito, hindi masyadong importante. It only indicates the direction of blood flow. So, red refers to the arterial blood and blue refers to the venous blood. Okay? Okay. Ay, wala na, tapos na. Pag-usapan natin yung intrauterine transfusion. So, ano naman tong intrauterine transfusion? So, intrauterine transfusion, intervention in the form of intrauterine transfusion becomes necessary. Ginagawa lang tong transfusion process na to when one or more of the following conditions exist. Naka-bold, naka-underline. Kapag ang amniotic fluid change in OD 450 nanometer, results are high in zone 2 or in zone 3 already. Chordocentesis blood sample has hemoglobin level of less than 10 grams per deciliter. And fetal hydrops is noted on ultrasound examination. Okay? So, pinaperform ito intraperitoneally by injecting yung RBCs doon sa fetal peritoneal cavity. Doon natin siya, inject yung needle doon sa fetal peritoneal cavity where the RBCs can be absorbed into the fetal circulation. So may disadvantage ito in ability to perform the procedure before 25 weeks and variable absorption of red cells. But meron tayong alternative dyan, PUBS or chordocentesis. So the ultimate goal of intrauterine transfusion is to maintain a fetal hemoglobin of above 10 grams per deciliter. So once intrauterine transfusion is initiated, the procedure is repeated every 2 to 4 weeks until 34 to 36 weeks gestation or until the fetal lungs are mature, when early delivery can be performed. So ano daw yung dugo na dapat i-transfuse doon sa fetus? Tatandaan, nakabold. Dapat group O, D negative RBC. Okay? Should be less than 7 days old yung dugo. Dapat fresh. Dapat may hematocrit level or amount or level of 70% or sabi sa ibang book, 75 to 80%. Dapat irradiated to prevent graft versus host disease. Dapat cytomegalovirus, CMV is cytomegalovirus negative. Dapat CMV negative siya kasi ang cytomegalovirus is delikado yan sa mga fetus, okay? Dapat hemoglobin S negative. Bakit? Kasi nga yung fetal lungs ni baby is immature pa that time. So dapat hemoglobin S negative. And of course, should be cross-match compatible with the maternal serum. So tatandaan yan 2, 4, 6, 7. 7 yan. Huwag kakalimutan na sa intrauterine transfusion. So ano pang pwedeng gawin? Pwede namang early delivery. Okay, ginagamit daw to for many years for moderate to severe disease to interrupt na yung transport ng maternal antibody doon sa fetus and allow exchange transfusion. Next, gumagamit din tayo ng phototherapy. Alam niyo yan, kapag nakakita kayo sa hospital, may nakatutok na ilaw kay baby. After delivery, phototherapy with ultraviolet light can be used to change unconjugated or yung indirect bilirubin to biliverdin. Infants with mild to moderate hemolysis, the use of phototherapy may avoid the need for exchange transfusion to treat hyperbilirubinemia and anemia. So, pwede rin natin siyang, meron ding serologic testing of the newborn infant, okay? Sa ABO grouping, tama, forward only, tama ba? Tama, di ba? Kasi wala pang, hello? Kasi bakit forward blood typing
Yes,
lang?
sir.
Oo,
Yes,
bakit?
sir.
Bakit?
Wala pa po
Wala
or
pa.
hindi pa yung
Antibody.
antibody sa
Antibody, sir, wala po.
cord RBC.
Okay, very good. RH typing, pwede rin gawin. Rarely, the infant RBCs can be heavily antibody bound with maternal anti-D, causing a false negative RH type or what has been called blocked RH sa RH typing. Kaya daw minsan, kapag mag-RH typing tayo sa newborn infant, ginagamit or ginagawa natin ang elution technique. Ano yung elution technique? An eluate from these RBCs will reveal anti-D and typing of the eluted RBCs will show reaction with anti-D. So gusto ko lang sabihin sa inyo na pag sinabi ng elution, ito yung RBC natin, andito yung antigen, ito yung antibody. So sa elution natin, tatanggalin lang natin yung naka-attach na anti-D doon sa antigen. So matatanggal yan, that's what you call elution. So ibig sabihin, ano naman yung eluate? Yung eluate natin, yun yung fluid. Okay, yung fluid kung saan nakasuspend yung antibodies. That's what you call eluate. So tinanggal natin yung antibody na naka-attach sa antigen, elution yung tawag doon. Para matest daw natin, sabi dito, an eluate from these RBCs reveal anti-D. Tama. Tinanggal natin yung anti-D doon. And then, pag itatype na natin yung eluted RBCs, yung RBC, pag sinabi natin eluted RBC, natanggalan ng antibody, this will show the reaction with anti-D. Kasi nga, na-expose na yung antigen kapag ni-react mo with the reagent na anti-D. Naintindihan ba? Hello? Hoy. Okay. Next, direct antiglobulin test. This is the most important serologic test for diagnosis of HDN using anti-IgG reagent. Naalala nyo ba? HDN is under DAT. Tama, di ba? Pag may HDN ka, you are DAT positive. Naalala? Yes. Positive result, okay, antibody is coating the infant's RBCs. However, the strength of the reaction does not correlate well with the severity of HDN. So a positive DAT may invalidate our age typing. Intindihin nyo nga, bakit daw a positive dot may invalidate RH typing? Anyone? Patawag ako. Tengay. Tengay? Hello? Hi. Hello? Ay, Gwyneth. Si Gwyneth na lang. Gwyneth?
Sir?
Sige, sagutan mo. Bakit? A positive that may invalidate RH typing. Bakit kaya?
Sir, paulit po. Hindi ko po narinig ng mabuti.
Sabi ko, bakit daw ang positive dot may invalidate RH typing? Yes? Hello? Ay. Sige, mag-isip ka ha. 5 minutes. What's your answer? Gwyneth? Hello? Hi. Sige. Hello?
Sir?
Anong sagot mo?
Sir?
Anong sagot mo?
Na-invalidate po yung RH typing ng dot kasi po,
Ay! Kinikilig ka?
saan po? Merong sir, dot positive may invalidate RH typing minsan sa RH,
Choppy kasi.
Ay.
Grabe yung connection mo, no? Anyway, sige, maghahanap tayo ng iba, ha? Si Heartweek. Feeling ko fresh itechi. Heartweek.
Sir.
Sige. What's your answer?
Oh my God.
Ay!
Sir, na-invalidate po yung, na-invalidate po yung positive dot sa RH typing.
Ha?
Kasi,
Basahin mo ulit.
na-invalidate po yung direct antiglobulin test sa RH typing because
Basahin mo nga ulit yung statement.
A positive direct antiglobulin test may invalidate RH typing.
Baliktad yung sinasabi mo. Ang sinasabi mo, na-invalidate ang dot ng RH typing. Yung statement, a positive dot may invalidate RH typing. Pareho ba yun?
No, sir. Sorry po. Sir.
Ay, hindi ako galit. Uy, sorry. Hindi ako galit. Ano na?
Sir,
Bakit? Tingnan nyo.
Sir, kasi po,
Kasi?
Sir, wait lang. Wait lang po.
Pakit lang ako sa picture.
Sir, di ko po alam.
Ay, bakit? Ba't hindi nyo alam? Mga Reyna, bakit di nyo alam? Okay lang yan. Okay, maghahanap tayo ng ibang sasalo sa'yo. Okay? Kaya natin to. Siyempre, si Julius Garo. Julius? Yuhu.
Sir, di ko din get, sir.
Hi! Agad-agad? Asan ka?
Sir, pwede mag-try?
Sinong Janine to? Janine?
Bakiran, sir.
Ay, hi. Go. Go.
Try lang, sir. Sa dot
sa that kasi sir, ibig sabihin parang yung may naka-attach na antibody dun sa RBC natin. So pwedeng mag-false positive po sa may RH typing kasi parang
False positive.
yes sir, pwede siyang mag-false positive yung RH typing sir kasi yung RBC pwedeng na-coat siya ng mga allo antibodies sir.
Wait lang. Tama ba yung sinabi ni Ja? May tama ka. Pero may mali lang. Tama ka, Ja. Tama. Okay yung idea mo. Sabi dito, 'di ba? Naalala nyo ba guys, ang positive that nasa HDN tayo. Sige, para maintindihan nyo. Hemolytic disease of newborn. HDN, mga kapatid kong kuba. Okay? Yung antibodies ni Mami, okay, iko-coat niya yung antigen ni baby. Example, ito yung RBC ni baby, ito yung antigen, ito yung antibody. Okay, na-coat, di ba? Hello? So, pwede kong sabihin na the maternal antibodies are coating the antigen on the surface of red cells of the fetus. Tama? Tama. Okay? Pwede ko bang sabihin na DAT positive to? Direct antiglobulin test to. Balikan natin si DAT. Ano na kasi yung definition natin for DAT, Ja?
Sir, ano po sir?
DAT. Ano yung definition natin? Ano yung pagkakala mo kay DAT?
Sa that sir, hello sir?
Hello. Ano?
Sir, pag sa that po, pag that positive po siya, ibig sabihin po, pag that kasi walang reaction. Parang
Hindi, balik tayo sa DAT. Ano yung DAT? In vivo or in vitro sensitization of RBCs?
In vivo.
In vivo po, sir.
Okay, in vivo. So, ibig sabihin, nandun sa loob ng katawan. So, ibig sabihin, sa HDN, may in vivo sensitization ba ng RBC?
Meron.
Meron. Ito. Okay, nag-gets nyo ba?
Yes.
Balik tayo dito, Ja. A positive DAT may invalidate RH typing. Bakit? Isipin mo ulit.
Kasi sir, parang na-quote nung mga
Wait lang.
antibodies.
Huwag kayo malito. Nasaan tayo? Newborn infant. Okay? Pinag-uusapan yung cells ni infant. Okay? Pinag-uusapan yung cells ni infant, hindi si mommy. Okay? Ulitin mo nga, Ja.
Sir? Oh my God.
Go lang. Ano ka ba? Hindi naman ako, M&M's.
Ano, sir? Saan part? Wait lang, sir. Sir? In vivo, sir, yung yung ni baby, parang na-coat na siya ng mga antibodies. Na-coat na siya ng antibodies ni mommy. Parang ganun ba, sir?
Oo nga. Oo. Tapos, bakit niya may invalidate yung RH typing?
Hindi ko lang sure, sir. Pero may possibility ba na parang, yung mga allo antibodies, sir?
Okay.
Parang,
okay. At least gets mo yon yung una. Sige, sino makakatulong kay Ja?
Sir, try. Charot.
Sino yan?
Vernice, sir.
Yes, Vernice.
Sir, kasi yung RH antibodies hindi siya naturally occurring. Na-produce lang natin siya kapag may stimuli like transfusion or pregnancy, ganun, sir. Tama ba? Ay, charot.
Lumayo ka na.
Ay, joke lang. Joke lang, sir.
Lumayo ka na, please. Nice try, Venice. Sino pa? Mag-isip nga kayo. Sino pa?
Ako, sir.
Okay, sino ka? Sino yun?
Eric, sir.
Ha? Eric, hi. Hindi kita kilala. Patingin nga ng face mo. Eric, dyan nakawala. Ay, hi. Kamusta dyan?
Hello, sir.
Kamusta ka dyan? Nakakain ka
Okay
naman
lang,
ba?
sir.
Nakakain ka naman ba ng mabuti? Oo, kasi parang
Yes,
Char.
sir.
Oo, ha, wag mag-skip ng meal. O, sige, try natin dito, Eric. Matawa.
Sir,
Hoy, eme lang yun. Oh.
ang alam ko, sir, is ganito lang.
Ah,
Tawag nun, mas accurate yung positive dot kaysa RH typing.
saan?
Sa pagtetest, sir. Kasi yung RH typing, pwede siyang mag-false negative. Kaya pwede niyang, yung dot, pwede niyang invalidate ang RH typing. At saka yung dot is in vivo siya. Which is, yung nagpo-focus siya sa red cell ng baby mismo. Yun lang, sir.
Okay, ang dami mo sinabi pero may tama na doon eh, no? Medyo ano mo na, medyo lumilihis ka pero andun ka na. Thank you Erica.
Yes, sir.
Ano ulam mo for tonight? Para ma-inspire naman kami.
Balatong.
Ano na nasusungot sa balatong. Ala, shocks, na-miss ko na yung balatong. My God. Anyway, sige, maghanap pa tayo ng iba. O, sino pa? Sino nagsalita kanina?
Sir, try po.
Sino yun?
Sir, try po.
Oo. Rogin. Hi, Rogin.
Si Rogin po.
Patingin nga yung face mo, hindi kita kilala.
So, madilim po ata.
Ay.
Pogi yan, sir.
Ay, pogi si Rogin. Sinong jowa, miss? Wala naman. Hoy, Rogin, ba't nawala ka?
Sir, wala.
Ah, okay. Pero,
wait lang. Sir, wait lang, nakasando ako.
Ay! Anong gusto mo? Magbabarong ka pa? O, dali na, Rogin. Diyos ko, anong oras
Sir,
na?
nakakahiya.
Oh.
Sir, a positive dot may invalidate RH typing. So kapag nag-positive po kasi yung dot, ibig sabihin, dun sa katawan mismo, nag-bind na yung antigen at saka antibody. So kapag tinype mo na siya sa RH, nung antigen nung RBC antigen nung bata at saka nung
okay.
nung bata sir at saka nung antibody ng mami. So ibig sabihin meron na po siyang dun sa katawan mismo ay dun sa in vivo na nagkaroon na ng binding. So kapag tinype mo na siya ng RH typing, maaaring mag-negative na kasi siya sir kasi nga wala ka nang ma-detect na antigen kasi na-bind na yung antibody ng mother sa antigen ng baby.
Wow, ang galing ni Rogin. Grabe. Patingin niya ulit si Rogin, hindi ko maalala. Parang di pa kita na. Rogin, ba't ka kasi nahihiya siya.
Hi, sir.
Hello. Oy, congrats. Ang galing mo. Tama si Rogin. Tama, guys? Hoy. Diyos ko, ito na yun, oh. Ito yun. O, tingnan nyo tong statement na to. Ito yung statement na to. Rarely, the infant RBCs can be heavily antibody-bound with maternal anti-D. Ito yung pinag-uusapan natin na HDN. Di ba nag-attach na yung maternal antibodies doon sa antigens ni baby, causing a false negative RH type or what has been called block RH. Kaya ang gagawin daw natin, elution. I-elute natin, tatanggalin natin tong antibody para ma-expose yung antigen ni baby. Nagets ba? Hoy.
Yes, sir.
Ay, may mga sagot si Rulu. Okay, gets nyo na? Okay. So, elution is the preparation of an eluate may be helpful when the cause of HDN is in question. As noted earlier, the resolution of a case block RH will require an eluate. So guys, thank you for sa mga nag-participate kanina, ha? Ayan. So, ayun, bumabalik na yung energy ko. Kasi dati talaga stressing me ako. So, kailangan lang nating maging, alam mo yun, balance para, diba? So, kanina napag-usapan natin yung intrauterine transfusion. So, when we talk about intrauterine transfusion ulit, habang nasa loob si baby, tatransfusan natin siya intraperitoneally. Tama? Yes. Pero, ano naman ang newborn transfusion? So the newborn infant may receive what we call small aliquot transfusions or exchange transfusions or both. Again, napanganak na si baby dito Okay. So indication, kailan ginagawa ang newborn transfusion? Kanina, sa intrauterine transfusion, 3 yon. Naalala nyo? Sa newborn transfusion, meron dito kapag may ginagawa to kapag may severe anemia, hyperbilirubinemia, about 18 to 20 milligrams per deciliter with increased risk of kernicterus. Meron ding low birth weight, okay? Low birth weight, sepsis or bacterial contamination sa blood ni baby, acidosis, and CNS deterioration. So ginagamit ang newborn transfusion to correct anemia when the bilirubin level is not high enough to warrant an exchange transfusion. And this is also used primarily to remove high levels of B1 or what we call conjugated or indirect bilirubin and thus to prevent kernicterus. So here are the benefits of doing exchange transfusion: removal of bilirubin, removal of sensitized or may nakadikit na antibody doon sa RBC, removal of incompatible antibody, replacement of incompatible RBCs with compatible RBCs, and suppression of erythropoiesis to reduce na rin yung production ng incompatible RBCs. So sabi dito, premature newborn infants are more likely require exchange transfusions for elevated bilirubin because their livers are less able to conjugate bilirubin. Alam nyo yan? Full-term infants with hemoglobin of less than 12 grams per deciliter, may anemia na yan. Hemoglobin level of less than 8 grams per deciliter, severe anemia, and it corresponds to zone 3 of Lillig graphs. Okay? So, ano naman yung kailangan nating i-transfuse? Group O, again, nasa newborn transfusion tayo. It should be Group O, B negative RBC. Number 2, should be less than 7 days old. At kailangan daw yung RBC na ito nakasuspend or it is resuspended in blood type AB FFP or what we call fresh frozen plasma. So ibig sabihin yung RBCs na to, yung liquid portion yung blood na ina-transfuse doon sa baby, yung liquid portion niya or yung plasma dapat niya or what we call FFP or fresh frozen plasma, dapat blood type AB. Why? Andyan yung explanation. For exchange transfusion, okay? Unique to sa exchange transfusion or what we call newborn transfusion, okay? One practice is to prepare RBCs from whole blood units. And then, i-replace natin yung plasma ng blood type AB. Bakit? To reduce the amount of blood group antibodies transfused. Okay? This procedure may be avoided if both the neonate and the mother are the same ABO group. Okay? So the hematocrit level here is 40 to 50%, unlike in intrauterine transfusion, 70% or like sabi doon 75 to 80%. Again, kailangan irradiated to prevent graft versus host disease, CMV negative, hemoglobin S negative, and cross-match compatible with maternal serum. Okay. Okay. Ayan. So may tanong ba tayo?